All right. How's it going, everybody? Good evening. Hope everyone's having a good week. End of Life Season 2. This is the second episode. We're back. It's going to be back-to-back episodes all months. So I'm very excited about today's topic. We're going to be talking about endo emergencies, which is kind of perfect timing because we're all just dealing with emergencies right now with this whole current crazy situation. And I have a very special guest joining me today, Dr. Sonia Chopra. She's a really great clinician and an educator and a speaker, and the list goes long and long and long. And she's amazing. I got to meet her last year in the AAE meeting, and she's such a great person to talk to. And I am very happy for her to join me today. And we get to talk about tackling endo emergencies. How's it going, Brett? I see you, my man. Let me see if I see Dr. Chopra here. Here she is. All right, let me just add her in. We'll get going. Oh, here she is.
Hey there.
How are
going?
you?
I'm
Good,
good.
good. How's it going? How's it going with you?
Oh, it's going. Just, one day at a time right
I
now.
know, I know. It's some crazy times we're living in right now.
I know.
And we're just I'm just, like driving myself crazy at home. I'm pretty sure you're just busy with the family and everything. Everyone's going well?
Yeah, I mean, I have a new job of homeschooling, so
I know.
that's been my biggest shift and change and
Oh
challenge.
man. Probably harder than endo, huh?
Way harder. Yeah.
That's awesome. Well, I'm so glad you joined me today. And I know we talked over messages and everything. We've been trying to do this for a while. And
Yeah.
we finally settled on a topic, which I think I was just saying it couldn't be at a perfect time with what we're dealing with right now, talking about emergencies.
Yeah.
Are you still open at the office?
We are. We are.
Okay.
Not as often. We're just 3 days a week.
Okay. Same with us.
Yeah, and then there's 3 doctors in my practice, so we're each
Okay.
taking a day, and we're rotating our team. Just to kind of deal with the concerns of our team. They feel, they're nervous, and so
Of
we're
course, yeah.
trying to minimize everybody's time in the practice, yet still be available and be able to support our community.
Oh, for sure. Yeah, I know. We're trying to keep people away from the ER and urgent care units, because they don't need more people flooding those rooms, they already
Yeah,
have their hands full. It's more risk for the patient, for the people
right.
there. So basically, we're trying to help as much as we can.
Yeah,
Um, all right, so let's talk about endo emergencies.
let's do it.
So let's do it. I mean, I know the ADA, AAE, and everybody has released their statements in this time defining what an emergency is, which is kind of like a little bit more strict than what we're going to be talking about because we're going to be talking mainly endo emergency, not a dental emergency, just mainly
Correct.
what is an endo emergency. So let's kind of like shed some light on that, just as far as definition goes. Like, why don't you share with us what is really an endo emergency?
Yeah, so I think this is like important, even like pre-COVID. I think people have always struggled with trying to figure out like what should be sent over the same day in a normal
Yeah,
day.
yeah,
Um, for me, I've always said that there's two true dental emergencies in the endo world.
yeah,
One is the guy or girl who's sipping on cold water because their own body heat is like elevating that temperature in their tooth, and they have a pain to heat symptom, and they
yeah,
have to swig on that cold, and pain meds are just not working, right?
yeah,
And the other one is typically a tooth that's been previously treated, and the patient has so much pressure. And those are the teeth that when you go to access and you start to get all that gutta perch out and you achieve patency, the exudate and the pus rush out of the tooth.
that's
So
right.
again, so I think if, for a simple definition, it's a it's a situation in which no pain meds or no medications are going to help the patient, and you really need to get into the tooth to provide some relief.
Yeah, you need some sort of intervention, basically,
Correct.
to alleviate patients' pain.
Yeah.
I mean, you run a busy practice. I mean, we have a fairly busy practice on our end too, and sometimes things can get crazy. Like
Yeah.
schedule's packed,
Mm-hmm.
and now the phone is ringing nonstop, and all of a sudden you have 4 or 5 emergencies.
Yep.
So I mean, this can be a little bit difficult. Like in a general practice, you have a leeway about referring, but in an endo practice, you're the person. There's no one
Right.
to refer to,
Right.
So I just want you to share with us on your daily basis, how do you manage those emergencies when they give you a call? Like, how do you fit them into your practice? How do you take care of those patients?
Usually I tell them to just come right over,
Hmm.
which
Yeah.
can be hard because some days you do get 5 or 6 emergencies
Yeah.
at a time. And
Hmm.
you already have a packed schedule because you also have to be productive. There's a
Hmm.
business to run at the same time. So there is a delicate balance between it.
Yeah.
But I feel like once we get the patient into our office, we can really properly triage them.
Yeah.
And, some people get referred out of convenience. Some people get referred because they're truly in a lot of pain.
Yeah.
Those people, like, I have a really big soft spot for them because I had a toothache once and it was an
Mm.
endodontist who saved me. So I'm kind of a sucker for a toothache, and I
Yeah.
don't
Yeah.
let people go home. But there's always a way to do it. And sometimes you talk to the patient and you say, okay, I'm going to open up your tooth. I'm not going to be able to finish your treatment right this second.
Yeah.
However, I have time tomorrow if you want to come back. And I
Yeah.
can probably get it done in one visit. And when you have that conversation with people, a lot of people will opt to do that. And so you can kind of manage your schedule that way.
Yeah.
Other people are just dying. They can't sleep. They haven't slept for 4 days, and they just want to get numb and they want treatment right away. They don't care what you get done as long as you get them out of pain.
Yeah.
So luckily, at least doing like a pulpal debridement or a pulpectomy, getting in, accessing, getting the patency, instrumenting enough, and medicating the tooth is enough.
Yeah.
Um, and you can numb somebody in another room, let them sit there, soak it all in, and then get in. And then that part of actual instrumentation takes about 15 minutes. So there's
Yeah.
ways to weave it into your schedule. Does that make
Yeah.
sense?
No, yeah, yeah, absolutely. I mean, you couldn't have said it any better. I mean, we do the same thing, really.
Yeah.
I tell my staff, when you have an emergency, just bring them in,
Yeah.
just right away. Because first of all, sometimes, although it sounds like an emergency to the patient, but
Yeah.
sometimes it's not an actual emergency. The patient's like, oh, I'm not in that much pain, but my
Right.
dentist told me you
Right.
have an infection. So
Right.
for me, this is an emergency. I was
Yep.
like, you're going to be okay. If we schedule you in a
Right.
couple of days, things are going
Right.
to be fine. So just at least to have myself look at it and, like you said, triage them.
Mm-hmm.
And like in instances where I have patients who are in like actual pain and need treatment, I tell them, listen, this is my schedule. I'm fully packed. I will take care of your pain today. Not
Yeah.
necessarily finish the treatment, just like you said,
Yeah.
but my goal today is to take care of your pain. I want
Yeah.
you to be flexible. I'm going to be playing musical chairs for the next 3 hours. So
Right.
I'm going to be jumping from patient to patient, but I'll take care of you.
Yeah.
Just because, like you said, the only reason we are still open because we're so passionate as endodontists, and tooth pain is something that we just cannot. I can't send a patient home with a prescription of 800 milligrams ibuprofen that I know very well is not going to do anything.
Right.
It's just this part of us that we really, dealing with patients' pain is what makes us passionate about what we do.
Mm-hmm.
And I think that's really across the board. I think every endodontist, how they deal with this, even if it's a packed schedule, you just fit
Right.
them in.
Yep.
So I really liked how you mentioned a patient's either sipping on like an iced water, or
Mm-hmm.
it's a temperature kind of pain, which is pulpitis, or like some sort of a chronic or acute apical periodontitis where it's a lot of pressure. So we're dealing either with a necrotic case or with a vital case, which can vary as far as your management goes.
Yep.
And your intervention can be different as far as an emergent treatment or service to that patient. So let's kind of like break it down and talk a little bit in details about how do you manage an emergency case, starting with, let's say, a vital case, like a very severe pulpitis.
Yeah.
Because there are different approaches on how you deal with to alleviate patients' pain.
Yep.
Obviously, doing the endo from start to finish, if you have time, that will take care of it. but you have a little bit of leeway with vital cases. Let's touch base on it. Talk a little bit about how you would manage it.
Well, first of all, I always take it back to diagnosis. To me, diagnosis is always king. 100%. I need to know what the diagnosis is. That means a pulpal and a periapical diagnosis, which I feel like some people like to skip over. But in my world, I don't believe in that. And that's how I teach it. You start with your diagnosis, because when you know that, you know how to anesthetize, you know how to treat, you know what treatment needs to be done in order to get them out of pain and keep them out of pain so they're not a continuous emergency. You'll know how to medicate them, and you'll know what to expect in the follow-up. So if you know your diagnosis, everything else will fall into place. So for a vital tooth, it depends. Is there percussion sensitivity? Because if there is percussion sensitivity, then you have to do a pulpectomy. It's not, a pulpotomy is just not going to work. Pulpectomy is where you got to go. A lot of times when the tooth is still vital, it depends. If it's like that late stage irreversible pulpitis, pain meds may not work. And antibiotics are really not what you want to do. So I like to, this is where I say treatment really trumps drugs, right? Yeah. And I try to get in there and do a full pulpectomy. So meaning my definition of pulpectomy is really completing instrumentation.
Yes.
So.
Yep. I totally agree. I'm glad you mentioned pulpectomy, because a lot of people reach out sometimes and they told me, I had this case yesterday and now the patient is so much pain. I was like, so what happened? So they tell me, like, this is what it looks like. And now I put calcium hydroxide, but the patient is still in pain. And I was like, well, why don't you walk me through what you did? I was like, well, I accessed the tooth and I put a slow speed round burr in the chamber. And then I quickly put a size 15 hand file into whatever canal I can find. Yeah. And then put calcium hydroxide in the chamber and send it. Stabbing the canals with files, you're just injuring whatever pulp tissue is inside the canal to make things worse. Yeah. So if you're going to put a file in the canal, I always say, if you decided to check patency on one canal, you're finishing instrumentation. Yeah. That's just it, I'm really glad you mentioned the pulpectomy versus pulpotomy. Pulpotomy can work in vital cases, but with normal apical tissue. You don't have any percussion sensitivity.
No percussion pain.
There's plenty of study. Hasselgren showed it. Very high percentage of pain alleviation, but you only need to access the only coronal part of the pulp. Nothing ridiculous.
No stabbing.
No stabbing.
Let's
not stab those canals. I think can be, but you know what? Like you said, maybe we just perform maybe a little bit faster. So for us, after accessing, like you said, it takes about 15 minutes to finish instrumentation. I rarely do pulpotomies.
Same. I don't even know what one is anymore. What are you talking about?
Yeah, exactly. But what I tell people is, like, if you legit cramp and you can't, just access the tooth, all right? Just control bleeding with irrigation only, and just place calcium hydroxide on the floor. Do not access the canals. Yeah. That will take you less than 5 to 10 minutes, if that's all you have. Yeah. That's a little bit of, sorry, go ahead.
No, I was going to say, right now, for those general dentists who are not comfortable doing root canals, a pulpotomy is great as long as there's no percussion pain. Yeah. And, and then, put a sedative filling in there and then refer, because everybody's schedules are so haywire right now that if you feel like you can't get your patient in and a pulpotomy will alleviate it, that I don't want to disregard the pulpotomy in this discussion. I still want to show that it could be important, especially right now.
Yeah, absolutely. 100%. And another thing, studies have shown if you have your diagnosis is an exaggerated lingering response to cold and percussion sensitive, which makes it a symptomatic apical periodontitis, it seems to be very helpful in alleviating pain to take the occlusion out. So if you adjust the occlusion, it will alleviate the pain. I actually, if it's possible, obviously, if you're accessing through a crown, that's a different scenario. But adjusting occlusion, it shows to, like, I made it across the board. If the tooth is going to get a crown, I said it before, take it down. Just take the tooth down and then, I made it a rule. I just usually adjust it. It helps with my working length determination anyway. And I think that's helpful too. So What about necrotic cases? I mean, necrotic cases are a little bit of a different ball game, you know. Like, and I'm gonna like leave it up to you. You know, like you tell me how you manage these, whether it's a virgin tooth, no endo treatment, or it's a previously treated tooth. You know, obviously, previously treated tooth is a little bit more involved of a procedure.
Sure.
But sometimes they show up in an emergency scenario.
Sure. So, in a perfect world, on a normal day, I would again do treatment, right?
Yeah.
And I would do a pulpal debridement. I would try to get in there, try to get patent. I would say if the tooth is necrotic in an emergency situation, if you don't find all the canals on that first visit, you may still be okay, unlike in a vital situation, right?
Such a good point, yes.
But in a necrotic situation, you could probably find that last canal in the second appointment if that was the situation. This is when your antibiotics are probably going to work. I know there's tons of studies that say, you know, antibiotics don't relieve pain, but I think we all know through anecdotal experiences that they do. You know, they will alleviate percussion pain. They will take down a flare-up. Yep. They do. And so I think right now, antibiotics are going to be a little bit overused. Yes. And they may need to be. Yeah.
Yeah. No, I'm with you on that. I had a discussion with Marcus Johnson, and we talked about post-op flare-ups, and we talked about post-op pain. And he's such a good guy. He's very like passionate, and he's always he just published a colleague for excellence about antibiotics and everything. And we talked about like overprescription of antibiotics. Yeah. And he's like a firm believer. And I told him, listen, Marcus, if your hands are tied and we're both doing one visit everything, you don't have the luxury of doing two visits, and your patients flare up, what are you going to do? It's like, I'm going to open the case and remedicate everything, which is fine, but I don't do this in every case. I prescribe antibiotics if a case flares up. And honestly, I have cases flare up more when they are sitting in calcium hydroxide than finished, you know, which is weird, but it's the way it is. And I agree with you. In necrotic cases where you're having scenarios like that, antibiotics help. Okay. Yeah. Antibiotics can help with that, especially if you're having a flare-up. Okay. Yeah. Retreatment can be a little bit more complicated. Like, let's say if I'm having a patient that finished a course of antibiotics and shows up with tooth number 14, obviously maxillary first molar, very apparent there's a missed MB2. The lesion is only on that mesiobuccal root, which happens a lot. Distal buccal and palatal are fine. I might access just to treat the mesiobuccal root, find the missed MB2, put calcium hydroxide. That usually takes care of the problems. Even if I'm planning on taking the rest of the gutta percha out for some reason, or doing selective retreatment, that can be addressed as an emergency measure just to take care of the patient. I sometimes do that. What do you do in cases where you have swellings, like an acute swelling, fluctuant? No, I'm not talking about those that are huge, which we could talk about later, but like a fluctuant swelling that you can see in the vestibule.
So again, I'm a treater. So I'm going to always get in there. In a perfect world, I'm going to get in there. Now, if I'm too busy, then I will just do an IND and stop. But I prefer to start treatment, medicate it, and then do the IND. And I like to do the IND after, so they're not drinking all that stuff under the rubber dam. So
good point.
Do
yes.
the IND
no,
after.
Absolutely. Yeah, absolutely. I open the tooth, medicate it, and then do an IND from outside. Right. Some people under the, my partner at work is like, I'll do the IND even if you saw the swelling went down, just to prevent any flare up that might happen. You give them a vent out, like make a small poke, just like let it out. Here and then, it depends. It depends on the swelling. What do you do if you have a firm swelling, something that you cannot incise? I've seen cases where it's not necessarily extraoral showing. It's still intraoral, but it's so tender to percussion, to touching, palpation, but the swelling is firm, like it feels like bone. What do you do in those cases? I mean, other than the treatment, do you recommend to be seen to take IV antibiotics or anything like that?
No, the only time I like refer to my oral surgeon for them to like maybe do a drain and some IV is when I see like really bad trismus and they're talking to me and I can tell that they're having difficulty swallowing. Then I'll call up my oral surgery buddy and say, hey, I got someone coming over right now.
Yeah.
And it doesn't happen often, but when I see them really not being able to swallow and like you can see them gulp, that to me is like a true emergency. They have to get the antibiotics via IV before I can even go in there. I mean, I can't usually treat anyway because the trismus is so bad and I can't get in there.
Yeah. I want to mention, like, because that I had, so this past year, I think I had about, I want to say 3 cases where I ended up sending them to get IV antibiotics.
Yeah.
But let me tell you what those cases are. Those are like some severe submandibular swelling that are like so big. Patient is telling me, I was like, can you breathe normally? It's like, now that you mentioned it, no, I can't take a full breath normally. It's like, you got to leave now.
Yeah.
Like this is going to become a medical emergency.
Right.
Or like patients that there's a maxillary swelling that's closing their eye. That's another one that can go to the cavernous sinus, and it can be also like very dramatic. Those are the cases I usually tell them, you got to leave now. I'm going to call the urgent care for you. I'm going to make sure they can put you on IV antibiotics. When you get there, they know what to do. And they usually feel better.
Now, the maxillary, you wouldn't want to treat that before you send?
If I can, yes.
Yeah.
But if I see cases, absolutely. I'm talking those cases of where you can treat it, or you can, like, for example, this maxillary one was such an involved treatment. It was 3 teeth, all of them with a huge lesion. Oh. So it's going to take, like, it's not going to be something that we can knock out in half an hour and send you there.
Right.
But if it's like, let's say it's a canine, I will open and med it and send them to get IV antibiotics.
Right.
But yeah, those are like very rarely happen, but I've seen it and it's scary. It's one of those things that, you know, like you got to be on your feet and just like know how to deal with them. And there's nothing more satisfying than when a patient tells you, or you call them the next day, I was like, oh my God, thank you so much. I can finally sleep, or like I can finally eat, you know, like it's such a satisfying feeling.
Or when they pass out because they're numb, you just hear them snore.
That's the best. That's the best. When I usually give 10 minutes. I walk out the room if I'm doing any block. Okay. Yeah. Any block, I give a block, walk out, and then come back.
People don't get numb. People don't get numb if I sit next to them. I'm like, I gotta go. I'll be back. They don't get numb.
Yeah. No, but I'm just like such an impatient person in general that I just want to get started. And then I obviously learned the hard way. I was like, just give the anesthetic time to work. So when I come back, I was like, how are you feeling? They're smiling. Yeah. They're talking. They're nicer to me.
Yeah. You get to meet the real person, right?
I know. Yeah. That's awesome. How often do you incorporate medication in alleviating pain? Like, do you have any scenarios? Because I used to be, so when I finished residency, I'm like a no medication kind of guy. But you go to the real world.
Real life,
Things are different because you got weekend calls, weekend walk into the office, and you have all these things that, like you said, they're anecdotal, but they work. They help. It might be placebo, but the patient feels better, then I'm happy. But what are scenarios like? We have main ones. We have NSAIDs, we have steroids, we have antibiotics, and also Norco. But I mean, tell me how you use these, or if you use them any.
Yeah. So first, I give everybody 600 milligrams of ibuprofen if they can tolerate NSAIDs before I start. Yep. So before I even anesthetize them. That way there's anti-inflammatories in them by the time they're done with my procedure. Now, if they can't have that, I'll pre-op med them with Tylenol. Yeah. And then post-op, I make sure they take for 3 days, pain or no pain, ibuprofen, 600 milligrams every 6 hours around the clock. Religious. Yep. Like, keep it on your nightstand. And if you happen to wake up in the middle of the night, make sure you take your dose. If not, expect to be a little bit sore when you wake up. Yep. I will say proper post-op instructions is so key when it comes to managing pain and anxiety, because if you can paint the picture for them for the next 3 days, no one's going to be calling you. And there's no one who hates like after hours phone calls more than me.
Oh my God. Yes, yes.
Because I'm just never near my phone when they call, and you know, it's crazy. Or my kids usually have my phone, so it's been hijacked. So good post-op instructions really helps manage pain and anxiety. Letting them know that, hey, every time I see a lesion on an x-ray, I tell my patients, you could swell. Because if you woke up looking like this and no one told you that that could happen, and it can happen day 1, it can happen day 2, day 3. So even reminding them that, hey, this may not happen right away. I may call you tomorrow and you may be fine on that phone call, but as soon as we hang up, the pain may come, the swelling may come. These are all variations of normal. And I remind them 10% of my patients are going to swell. And if you do swell, you need an antibiotic and or a steroid.
Yep.
Okay. I would say my biggest offenders of like a post-op flare-up is the lower molar retreat with a lesion.
Yeah.
Right?
Classic.
Big difference between mandibular and maxillary too, I feel like.
Maxillary, in my experience, rarely flare up in comparison to mandibular. I'm with you on that. I sometimes prescribe mineral dose pack in some post-op pain of a vital case, which seems to help.
If they can't touch their teeth.
Yeah, and especially if I take everything out of occlusion and everything looks fine, no extra canal, no nothing. Obviously, I take CT if I need to. Sometimes mineral dose pack for like 10 days help, you know, and they come back after 2 weeks and like, I feel great. I was like, good. But yeah, I'm with you on that. I'm going to go through some questions here that we have. So when we talked about vital pulpotomy, people are asking, do you still put formocresol for pulpotomy? We don't do that. Yeah, exactly. we don't do this anymore. There's no more formocresol. I don't think in pedo, I think some pedodontists still do it, but on primary teeth. But I think just you don't have to. Just sodium hypochlorite, you know, like that's it. Just take the coronal pulp out and then just place calcium hydroxide. Let's see what else here. So only when it reaches cellulitis you use antibiotics. Correct. Yes. And we also mentioned about some post-op flare-ups to prescribe antibiotics that can help as well. So cellulitis, yes.
I will prescribe an antibiotics when sometimes the swelling isn't cellulitis, it's kind of a mixture. So usually when I see swelling, they'll get an antibiotic.
Same here. Same here, yes. Let's see. It is scary. Yes, absolutely. Cellulitis is scary. So let's see. Oh, if you have a fistula, you do the IND, and is it necessary?
No, fistula is your antibiotic. It's amazing. It's getting rid of it for you. And it's almost like a homeostatic environment. So like, don't touch it. Don't like, just leave it alone. They're not in pain unless they like palpate the area. But a sinus tract or a chronic apical abscess, in my opinion, is not a true dental emergency. It's not.
That's right. And usually they're asymptomatic. All they can tell you is that I see this.
Yeah.
And if I poke it, there is some yellow stuff comes out. That's all their chief complaint. It's usually asymptomatic. As a matter of fact, I usually one visit every treatment in my practice. I want to say like easily 90%, 95% of my treatment is one visit. If there is a case that I can sleep better at night and I know it will never flare up, is a sinus tract case. Because you have a vent out already. So this is not going to build up and build pressure in a point to it's going to make pain. So it's nice to have a sinus tract and you two visit, and when the patient come back, you see that it healed, just for you to feel better that it's going in the right direction. But you and I both know that the sinus tract, if the treatment is not going to work, it might come back.
It's your friend. The sinus tract is your friend. That's what I tell my patients. That bump is your friend.
I like that. No, that's good. I'm going to use that in the future.
That's a good one.
It is. So people are asking, do you prefer sodium hypochlorite or chlorhexidine?
Hypochlorite.
100%. For irrigation of endo, sodium hypochlorite, there's no better irrigant than that. You can use EDTA or chlorhexidine alongside it. That's fine. I don't personally use it. The only time I use chlorhexidine sort of material is for the patient to rinse before surgery.
Mm-hmm. You don't
I
want
mean,
it. Did you ever use it in a retreat? Because that's what I was taught. And
yeah.
so back in the day, you're
Okay,
frozen.
here you go. You're back. Can
Okay,
you hear me now?
sorry. I
No, that's
can.
all
It's
good.
perfect.
Okay. So people asked what's the difference between fistula and sinus tract. I answered that while you were gone.
Yep. I
I
heard
think
it
it's just a
actually.
different term. Oh, okay. All right. Let's see. What's the best way to? Oh, they're asking if you medicate the roots between visits. Well, yeah, we do. If we put calcium hydroxide in between visits. So, do
Hmm.
you use any sort of other medication, Sonia?
No, just calcium hydroxide.
No?
If I do 2 visits, I don't really do that anymore. With Gentle Wave now,
Yeah.
it's changed my all my protocol.
Oh, yeah. Oh, for sure. Absolutely. Yeah. Gentle Wave is just amazing. It changed the game.
Yeah.
Um, let's see. Is sodium hypochlorite sufficient? Do I really need calcium hydroxide on top of that, or just irrigation is enough? We talked about that. If we were single visiting, that means there is no calcium hydroxide.
Mhm.
I majorly do one visit, and I think Dr. Chopra would do the same, I'm
Yep.
assuming.
Yep.
Yep.
I don't
All
like to
right.
leave my
So,
canals empty, right?
yep,
If
yep, absolutely. It's either gonna percha or calcium hydroxide.
exactly.
Um, so some people are asking about trephination,
That's
um,
a good question.
which is drilling through the cortical bone into
Hmm.
the lesion instead of just an IND through soft tissue. So it's a like small round burr going through the bone for people
Hmm.
who don't know what trephination is. What's your experience with that? I've done
I've
it one
never
time.
I've never done it.
I've done one decompression case in residency where I
Mhm.
sutured the drain inside and all
Yeah.
of that and let it drain. But I never used a drill. I just
Right.
used a huge 18 gauge needle because I have a CBCT, so I know there's no cortical plates.
Right.
But I don't really do trephination. I think it's a little bit of an aggressive procedure. And I think there's like mixture of studies showing different results. So it's
Hmm.
not really a reliable technique to alleviate pain. And obviously, like we talked about it, like endo's getting so much faster. The best way is treatment.
Right.
Um, so let's see what else. Sinus tract drainage extraorally through the skin. I have never had a case like this. I've seen
Hmm.
it,
Yeah.
but I never had to deal with it. Usually, those cases are associated with a huge swelling that ended up poking out through the skin. And those
Yeah.
are the cases I might send them for IV antibiotics if I feel necessary.
Hmm.
And probably an oral surgeon at a hospital will take care of that.
I've done
Um,
one. When I was in my GPR, I did one with
okay.
my oral surgery attending. It was kind of
Yep.
gross. It
Yeah.
it was almost like pouring out a gallon of milk. You know that sound? It was like
Yeah.
that.
Yeah. 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 It's I've never had to deal with it, and probably that will be still my approach if I see one. Just I think the patient will be in a better environment to be taken care of, to send them in a hospital setting. A lot of people are asking if there's any difference between medicating the roots or not.
Hmm.
I don't think there's any difference between one visit versus 2 visits.
Right.
A lot of people are firm believers in that, but things are changing. Our irrigation protocol, like Dr. Chopra mentioned, gentle wave, activation of irrigants, all of that. If you can clean it well and you feel confident about your disinfection protocol, just fill it.
Yep.
That's just my perspective. I think that was the last one in relation to emergencies.
Hmm.
Anything you want? I'm going to leave this up to you for a little bit. If there's anything you want to cover before we head out, if there's anything you want to mention before I let you go.
Um, yeah, I think right now is just a really unique time, and I want people to know that, there's still ways to support like everybody, and especially the endodontists. Like right now, we've successfully launched our teledentistry, but it's always good when we get more information. So if right now you're not seeing patients and you're really leaning on your specialist, still help them out. If you have like a previous FMX picture, it doesn't even have to be like a recent radiograph, but if you have an FMX that you can share, it'll help us with that diagnosis so that we can know how to treat in these emergency cases right now.
Oh, absolutely. Absolutely. It will help so much. That's a really good
Yeah.
point. And
Mhm.
unfortunately, I can't, sometimes the offices are busy and they can't even send a single x-ray.
Yeah.
And I'm like, I just want to know when I can squeeze this patient in my
Yeah.
schedule.
Send
So
us
help me out.
x-rays.
Help me out
Send
a
us
little bit.
x-rays.
Yeah, yeah. Dr. Chopra, thank you so much. You're such a
Thank you.
pleasure, and you're always, like so much fun to talk to, and such like a bank of knowledge. So thank you for sharing your time with us, and I
Thanks
really
for having
appreciate it.
me.
Absolutely. I'm really bummed that we didn't get to hang out this year. It got canceled, but
I know.
definitely next year. We'll
I'm
we'll
really looking forward to it.
same here. Same here.
Yeah.
I'm gonna let you enjoy the rest of your evening. Thank you so much, and you have a wonderful evening. Okay.
Good night. You too.
Bye bye.
Bye-bye.